Okay, welcome everybody. Glad that you all are with us today. My name is Kathy Kinlaw. I'm the Associate Director for the Center for Ethics here at Emory University. We're really thrilled to have our speaker today, who I'll introduce in a moment. Just want to mention a couple of things also for today. We do have a Healthcare Ethics Leadership Academy, which we would encourage healthcare providers or those interested to look at joining us for. And it's a 18-month program, including participation in a graduate course and then ongoing capstone opportunity. And we're looking at applications by June 16th. So if you want to know more, ask us, please. And our second, this summer there's going to be a really wonderful course called Memoirs of Illness, looking at narratives of people who've experienced illnesses of all sorts. And we would welcome your considering applying for that. You would need to be a student in special standing, which we could help you with, but we'd love to have you consider joining us. So people from the community, in addition to our Masters of Arts in Bioethics program, and others are joining us for that. So I wanted to make sure you were aware of that. And now it's my pleasure to introduce our speaker, Dr. LaShaunda Reese, who is a senior clinical ethicist with Advocate Health System. She's had a lot of great experience working as ethics consults and policy review, but she's also a adjunct faculty at Morehouse College in philosophy and religion. She actually is returning home here today because she has a Master of Theological Studies from Candler School of Theology, which is upstairs in this building. And some others of us are graduates as well. So we're really, really pleased that you're here, LaShaunda. We don't take lightly you're giving us this time, and we look forward to hearing from you.
Oh, good afternoon, good light evening, everyone. Normally I would be standing in very ambulatory as I'm almost 6 feet, but I'm currently down to one leg. And so you are only graced with half of me, but I'll make sure to try to make up for the half that you don't get exposure to. So as Kathy graciously said, I am a clinical ethicist as well as an adjunct professor, so able to integrate both practical studies as well as theory and also try to stay up to date with the students. They keep us current in more than one way. Of course, letting you all know that there are no conflicts of interest or obligation with this presentation. There was no paid advertising or marketing on my behalf for any part of this presentation, so I always want to put that in there. So I always like to start off with a quote that I think kind of rounds out or summarizes the content of my presentation. And so I decided to pick a quote by Toni Morrison. And the quote is, "The crucial distinction for me is not the difference between fact and fiction, but the difference between fact and truth, because fact can exist without human intelligence, but truth cannot." And so what we'll be doing is focusing on the narrative aspect of things like ethics consultation and requests, and looking at how the truths come about from patient perspective, care team perspective, and even in the midst of patient and surrogate refusal, how might we gain insight into those narratives to be able to partner alongside patients, surrogates, and other care teammates for positive outcomes for patients. There it is. All right, now, learning objectives. So there are four main things that I'm hoping that you all will at least have some kind of inkling towards, if not, guaranteed experts in the subject matter. I hope that you all are able to distinguish between capacity and agency. I think those two sometimes are used interchangeably, and we want to make sure that we distinguish because we need to be clear about what it means for patients who lack capacity to still enact agency. The second thing is we want to be able to define critical empathy in the context of healthcare. So critical empathy is more of a theoretical term that's more so used in literature and other fields. But when we put it in the context of healthcare, it actually becomes extremely helpful for physicians, care teammates, and clinical ethicists, especially when we're trying to parse out value-laden, complex dilemmas and issues. I'm also hoping that you all can start to identify the narrative aspects of patient stories and care team concerns, right? So we are narrators by nature. It is, in a sense, how we communicate, whether verbal or nonverbal. How we interact tells a story. And so being able to emphasize some of those aspects within a consult request, within speaking to a patient, within a water cooler break with a care teammate can really help us to distinguish, one, what are some of the more personal, professional, emotional, psychological aspects that are contributing to a person's perspective, as well as what are some of the environmental aspects, external stimuli, and things of that nature. And then finally, hoping that you all will leave here feeling empowered to promote the narrative perspective in patient care, to contribute to patient outcomes and patient surrogate refusal. So I don't want us to contribute to patient surrogate refusal, but I want us to contribute to positive outcomes within patient and surrogate refusal. So make sure we clarify that. So we are familiar with our 4 kind of pillar principles for clinical ethics, so I won't take too much time going over them, but they are the foundation and some of the most commonly used concepts when we're trying to decide which ethical principle takes precedence or which one should be prioritized in navigating dilemmas. What we talk about more in special areas are some other aspects of clinical ethics, including the notion of confidentiality, whether that be maintaining a level of privacy among patients or as it relates to perhaps being subpoenaed to provide ethical expertise for purposes of guardianship and what that means for institutions and your position as an ethicist. We also note the dignity, and that's one of the aspects that I'll be focusing on today, specifically with patients who lack decision-making capacity but still enact agency, is that enacting agency is an expression of dignity. And so it's very important to distinguish capacity and agency as well as connect agency and dignity. And then also truthfulness, honesty, transparency, having humility within the field. So this connection between patient autonomy and capacity, right? Respect for patient autonomy as one of those principles is connected to healthcare through this concept of decision-making capacity, right? And so decision-making capacity has roughly, give or take, 4 notions that physicians look for to determine whether or not a patient has capacity. So the ability of a patient to understand the nature and consequences of a proposed treatment or procedure, as well as to appreciate the nature and consequences, right? So there are 2 parts to that. We want to make sure that patients and individuals are able to make a reasoned choice among treatment options. We'll see buzzwords like reason and rationale, but we just want to make sure that individuals are able to use their intellectual capacity to come to the best decision for them. And then we want them to be able to communicate that choice. And communication spans well beyond verbal utterance, right? We have nonverbal expressions, we have written expressions, we have sign language. And so we want to make sure that patients have the ability to communicate that choice. So the interesting thing that I have found as a clinical ethicist regarding decision-making capacity is that although we have these 4 concepts, what we seem to think, at least physicians, is that there's either an absolute or a spectral idea of decision-making capacity. We usually see the absolute idea from physicians. So either the light is on or off. It's on-off switch. Either they have capacity or they don't. In reality, it's more like a dimmer switch. And so if you think about a dimmer switch, the more it's turned closer to on, the more clear objects are, whereas the farther it's turned to off, the less clear things are. And so the reason that this is important, because we know that there's a saying A&O times 3, A&O times 4, which literally gives us a spectrum of capacity from a physician's perspective. But we need to be able to translate that to non-clinical. So what does a spectral perspective mean, right? What does spectral capacity mean? It means that although an individual may not be able to make high-level medical decisions, they can do things like identify family members, identify their favorite cartoons, and also tell you what they do and do not want to happen to them, right? And so despite decision-making capacity, individuals and patients do have the ability to express agency, and that agency includes the ability to refuse as well as to designate decision makers on their behalf. So talking more about agency, because this is just very important with our incapacitated patients, right? We usually don't get ethics consults for ideal cases. They're usually for exceptions or for cases that seem to be a little bit more creative than what the textbook has prepared our care team for. So when we think about agency, it's just simply about the ability to participate in some aspects of decision-making. Now, some could literally mean one. It literally could mean they only have the ability to identify who can make decisions for them. And that's enough. Any kind of agency that patients or individuals express, we want to recognize and acknowledge, and we want to take that into consideration, even if the outcome of the consult or the dilemma does not change, right? It's cause for pause. And so there are a lot of instances where care teammates have complex situations and they're dealing with patients who are expressing their agency, though they lack capacity. And it brings up a dilemma of whether we should honor the respect for that patient's autonomy via agency, right? Because they lack capacity, or rather we should just enact beneficence and do what's good for them, right? Act in accordance with their best interest. And so agency helps us to remember that, whatever extent or capacity individuals can express how they want to live, how they want to die, and what's important to them, we want to take that into consideration. It becomes a little bit more complicated when we feel like those considerations are contradictory to medically indicated interventions, right? Or what we would commonly do for similar patients in similar circumstances. Nevertheless, that really adds to the beauty of the right and the fact that patients have the ability to refuse. Despite how informed we try to get them and their surrogates, despite the numerous care conferences, patients have the ability to determine their care. And so then the question becomes, how are we able to respect that in a way where we can still provide them care and allow them to lead and guide those decisions? What's important for us to understand is, unlike capacity, agency is absolute. So while capacity can fluctuate, everyone has agency, regardless of their position in this kind of healthcare dynamic or context. And so we just want to be mindful that agency is connected to dignity. So this idea that it is something that is not bestowed upon humans by humans, therefore cannot be taken away by humans. And so it's the same thing with agency. So talking about narrative medicine, I'm a narrative ethicist, a womanist narrative ethicist. And so my dissertation and a lot of my research is on the importance of storytelling in the context of healthcare to help create better patient outcomes while expressing preferences, values, and beliefs, as well as positions in the socioeconomic and political circumstances that one finds themselves in. So when we define narrative medicine, it's really a methodology, right? It's a way of going about doing things. And it's a methodology that specifically focuses on a kind of communication via storytelling. When I thought of storytelling, I thought of someone sitting in front of me or a group of individuals and reading a story, but it's so much more than that. Teachers are storytellers, preachers and pastors are storytellers, right? Cashiers are storytellers, right? Hairdressers. So anytime there's communication where there is subject, action, and a verb, right? Or even not, it's telling a story. No tells a story. If you ask me a question and I say no, there's a narrative behind that. And so how can we better elicit what is undergirding that response in a way that we can be more respectful of that and pair alongside it? It's important to understand that there are multiple narratives taking place at one time. So the narrative of the patient has to do with the narrative of their social identity, the narrative of their family dynamics, the narrative of the site that they're receiving care in, the narrative of the city, right? So there are many, many complexifying narratives that come into play when we're talking about patients and how they wish to receive care. And although it may sound overwhelming, a lot of us already subconsciously consider many of these things before we even interact with other individuals. We consider if there are language barriers, if there are cultural barriers, if there are religious barriers, or if there are just differences that we're not aware of. So we come in with an uncertain humility, I would hope, and being open to this idea that we too will encounter a narrative that, while it may question our point of view, it will also enhance it, especially in terms of partnering with individuals in their wellness. The last 2 points are specifically related to the healthcare context, right? So illness, disease, wellness, while these do have definitive phrasings, they're all relative based upon their context. And so what illness is considered in one culture may not be considered illness in another. And so just being mindful of kind of the socio-cultural influences that are present within healthcare. And then also understanding that narratives are subject to the narrator just as they are subject to the audience. And so we can all hear the same story and each have our own interpretation. And that's kind of what happens when we encounter patients in healthcare. Based upon our personal as well as our professional expertise, we have a certain lens of interpretation. So I wanted to go into some reasons for refusal, or some reasons that the narrative may come out as a no. It is founded in the principle of autonomy, right? And it's usually termed as informed refusal because we usually like to phrase these expressions of capacity through rational patients or through patients who have neither been deemed incompetent or incapacitated, right? But we need to make sure that we understand that there's a difference between informed refusal and patient refusal. So any patient can refuse at any time. I think this is very, very difficult for physicians to hear, especially those who lack decision-making capacity, right? But I have yet to come across any state law that says we have the right to coerce or force a patient to medicate them, to restrain them, unless, right, there is immediate harm to self or immediate harm to others. And then it's usually a very strict, time-limited, highly monitored, regularly checked upon circumstance that they revisit frequently because the goal is to minimize harm to the patient even while trying to provide what's best for them. It can also be an expression of agency. We've seen many of times where individuals who may be institutionalized, maybe they have been in and out of the criminal justice system, maybe if they've been in foster care, and so they really feel historically that they have no control over their lives. And so coming into another institution via healthcare or hospital and being inpatient, there can be similar feelings of loss of agency and autonomy, but there are absolute expressions of that via no. And so a lot of individuals who are marginalized are very aware of when they can say no. And even if they're not aware, they still test it. And the concern becomes, one, if no, then how can we help you, right? And then also, if no, what is it that you expect from us? Similar to how I'm working with this mouse, there seems to be sometimes a disconnect, right, between two parties. And this can be, if we're dealing with individuals who are on the spectrum of capacity, we have to be mindful of what language is best used to convey what we're trying to convey, right? So you can't say angioplasty to someone who is A&O times 2, or you could, but you're not going to get the response that you need, right? And so being able to translate to decrease misunderstanding so that individuals, for example, don't hear palliative care and think, oh, you're just going to send me home to die. No, right? Explaining, well, palliative means this, and this is what, services are provided. And I know this is what you have heard or you may think of as palliative, but this is what it's different from, or this is what it's distinguished from, right? So misunderstanding is a large indicator of why patients, especially those who have a spectral decision-making capacity, may refuse. And then fear. I think fear is a very adequate and very obvious reason for refusal. Fear of the unknown, fear of loneliness, fear of unintended or misunderstood circumstances regarding whatever consequences may come from either doing or not doing the procedure. You're kind of afraid either way, right? And then, of course, we have our disagreement between our patient and surrogate, or disagreement between the patient and the care team, right? The care team says, look, the prognosis is extremely poor. We're doing more harm than good to the patient. We're losing blood and transfusing. And the family says, well, my God is a miracle worker. And so we're going to do everything possible. And I don't care if you hook them up to every tube, plug, and plant in this place until a miracle happens, right? So we have obvious disagreements, which are just a competition of values, right? They're competing values between what the patient / family believes is best and what the care team believes is recommended and in the best interest. And that's just a child saying, oh no, because sometimes patients are very adamant and verbal and visual and belligerent, but it's really an expression of agency. It's like, I want you to hear me. I want you to respect that this is what I'm saying. So how can this be helpful for us, right? So ethicists and ethics expertise, and I say ethics expertise because I think everyone in healthcare should tangentially be an ethics expert. So I think we must engage in strategic conversations when conducting fact-finding. We ask questions with a little bit different bend to them, right? Because we have different goals that we're trying to reach. And so there are a couple things that we need to consider. We need to be mindful of the position that we have, right? Because as ethicists, again, we want to try to hold objectively neutral spaces. And a lot of times by the time that we are invited to these spaces, they are highly polarized and tense. And so we're really coming in and putting out fires while trying to promote places of peace and conversation. And so you want to be mindful of how the physicians feel, how the nurses feel, how the other care teams feel, and as well as how the family and the patient feels. We want to be mindful of any personal beliefs or values that complexify the concern, right? We have had individuals who have had very strict religious/cultural implications. And so we can't speak to the women in that family. We have to wait till there's a male present, right? Or we are unable to speak to anyone who is not married in that family, right? Or we have to have an interpreter there because even if they speak English, they only want to be able to make decisions in their native language because they have family on the other side of the world. And so being mindful of those things and knowing that prior to coming into the conversation so that while you may need to guide it, you can guide while going alongside individuals. And then, of course, consider the site, department, or unit culture if necessary. So usually bigger organizations, each site or each demographic area is going to be a little bit different. Each patient service area, if they're more rural, if they're more urban, if they have a high Sikh population, if they have a high Muslim population, if they have a high Nigerian population. And so those things are going to contribute to the culture at these sites. And that's also a major factor in how care is delivered. And then we want to have active and intentional listening. A lot of times people call us the vent, and it is an hour in, and they're like, okay, so let me tell you what's going on with the patient. And you're like, yes, okay. And so we want to be mindful of our active listening, but we also do want to provide that psychologically safe space because a lot of our care teams are what I call existentially exhausted. They have went from the pandemic to racial upheaval, to now the current political. I mean, it's one thing after another. And so there is some point where our essential workers are exhausted. And so they do rely on us for those moments of peace and contemplation and processing so that they can go back out and do their jobs on the front line. We also have to have an ear to guide conversation. So one part of that is listening and allowing that individual to get out what they need to get out. But then we have to ask pointed questions so that we can figure out what's the ethical concern amidst the grievance that you're bringing to us. Because Hillary had a presentation last month and she talked about moral distress. And so we see a lot of moral distress, which is a different kind of ethical concern. And we have different resources to help address that. And so we need to figure out if this is an end of life concern, if this is a moral distress, a moral uncertainty concern, or if this is a values-laden conflict where the goals of care don't align between the care team or the patient. And then also translate narratives into comprehensive synopsis. So you may have to call the physician and they're going to have a narrative. You're going to talk to the requester, they're going to have a narrative. You're going to talk to the nurse, they're going to have a narrative. But are you able to take those narratives and make your own narrative in a way that can clearly state, based upon all the stakeholders, this seems to be the primary concern, right? And so although you're conducting fact finding, what you're really doing, going back to Toni Morrison's quote, is you're extracting the truths, right? You're extracting the humanness out of these things because that's what ethics really gets to focus on. We let you physicians focus on the clinical stuff. We focus on the human stuff. No, I'm just kidding. Those should never be separated. So when we're talking about narratives and we're talking about how to interpret and make the synopsis, this is where this idea of critical empathy comes in. So it's literally a combination of critical thinking and empathy. But if we're defining empathy in the context of healthcare, right, it's understanding the personal experience and the humanness of the patient, but without bonding with them, right? So empathy, there's a boundary, right? There's an authentic engagement, but there's also a safe boundary. And that boundary allows you to take into consideration their experience without being affected by it. And that's really important because we know that you all deal with some very, very emotionally toiling situations. And if you allow them to affect you that much, then they may impact how you function. And so you want to be able to connect with patients in a way that still allows you to safely do your job and interact with them. Now, critical thinking, right? This capacity to deliberate about thinking, but also be able to regulate your thoughts and emotions, right? So being critical about your context, your position, your identity, some of your biases, right? Before you come into conversation or come into space with other individuals, be mindful of that when you are engaging, because that will allow you, one, to be more open and be more authentic, but be conscious, right? You want to be conscious of how you approach individuals and how you approach situations. And then so critical empathy is really just this practice of understanding and appreciating the perspectives and emotions of others, right? So feeling empathy, while also critically examining the socio-political and historical context that shape the patient and the self's perspectives. So we don't want to just separate, patients and surrogates and care teams from whatever position we have, because we're all human interacting. So I'm saying I don't want you to detach who you are from engaging with patients. I want you to be aware and mindful of that and use it as a way to connect in a safe and professional manner.
So I find it interesting that you said with empathy, we shouldn't be bonding with the patient. And I find that when I express empathy, that creates a bond with the patient. So are you suggesting that we actually not distance ourselves?
No, what I'm suggesting is that you make an avenue for yourself that you can develop an authentic relationship that doesn't have to be sacrificial. Because what we do see is that nurses will develop relationships and then they will be physiologically impacted, which sometimes you can't control because, again, we're human. But if you can, or if you're aware maybe that this patient is similar to your brother or uncle who just passed, and you know the situation and you already start to feel emotions boil up, are you able to either partner with someone and you be like, hey, lady, keep me in check because this reminds me of my uncle? Or can you do something like maybe recuse yourself because you don't want to impact the care that the patient may receive? I would never say not to connect with people, because I think we meet people at some of their worst times. And so what they need more than anything is human connection. But you have to be able to do so where you can maybe do so 30 times in a shift. And so how can you do so in a sustainable way? So where you don't go home and you just don't have anything left. Even the dog is like, am I gonna get fed? And you're like, oh, got it. And so we want you to be able to connect in a way that doesn't take so much from you. And I think being mindful of, I want to acknowledge what this person is going through, acknowledge how they're expressing what they're going through in a way that I can walk out knowing I've done my due diligence. Thank you for asking that, because I don't want people to think that I don't want y'all connecting to humans. The humanity is one of the primary emphasis here, especially when we're able to enact our agency by saying no. And so I want to be mindful that we always want to try to connect with individuals, but we live in an exhausting time. So I think we have to be creative with our connection. Okay, so I like this diagram, but it's not technically in order. So don't mind the fact that the A, B, C goes like a clock, but we're gonna start at the top left, Lord. So A, acknowledge, right? Critical empathy has 4 parts. So acknowledge and it should be prioritized the experience and concern of the patient, right? Part of active listening. Be mindful of the social, political, and economic circumstances that contribute to the patient's narrative. Yes, it is more likely that African-American patients will refuse treatment based upon historical medical mistrust, right? At this point, it's something that I'm hoping is still taught in medical books and medical schools, but if it's not, it's definitely Googleable. But just be mindful of things that are contributing or perhaps may contribute to your patient's present circumstance. See, we want you to consider the specific impact of medicine in healthcare on individual and social narratives. So again, using the African-American perspective, individuals might have resentment towards different ethnic groups that may be completely separate from medical mistrust, right? So then you have to consider how might the medical aspect add or complexify this context that we're in, especially if it's a power dynamic where if I am a male physician and it is a female patient, right? Or if I'm a Sunni physician and it's a Shiite patient. So being mindful of how medicine and healthcare adds an additional layer or narrative to what can already be a complex dynamic. And then D, distinguish one's own understanding as but one perspective in the narrative. We don't want you to disconnect or detach yourselves. I think the interesting thing about clinical ethics work is that each ethicist has their unique way of how they express their profession. And that's because we're each different individuals. And we don't want to diminish that. We actually want to emphasize it, but emphasize it in a sustainable way. Okay, so we have 2 partial cases. How are we doing on time, boss? 31. Oh, we are zooming. Okay, good. We're gonna have time for discussion. Wonderful. So these are considered, I call them partial cases, right? I set the case up, I give some questions for conversation, and I give a little bit of discussion, but I don't give the outcome because the goal is to actually focus on the narrative and not the outcome of the consultation, and look at the difference narrative adds or the significance that it adds when we're trying to figure out how to go about addressing clinical and ethical dilemmas. All right, so Patrick is a 52-year-old who presented to the ED from a group home for leg swelling and possible gangrene. He has a history of schizophrenia, hyperlipidemia, hypertension, COPD, and has a corporate guardian. A workup reveals recurring admissions for the same issue, an advanced infection with a recommendation of a below-knee amputation. Patrick is adamantly refusing, stating, "I'll die before I lose my leg." Though the guardian is difficult to consistently reach, they are consenting to the recommended amputation. So I want to open up this time kind of just for initial thoughts or responses or concerns, especially those who are watching virtually. Is there any additional information that you would want before you try to figure out options for Patrick? Is there something that sticks out to you? Is there something that's missing? What do we think? Yes.
I'm curious about race. I'm curious about if there's a faith tradition. Because I'm wondering if there's some more demographic information that'll get me to, I'll die before I lose my leg.
I appreciate that. Yeah, so there is no identifying information about this individual other than the age, which may or may not be, we don't want to be ageist. So we appreciate it, but we don't want to use that solely in determining. Is there anything else missing or anything that jumps out to anyone? Maybe that be online or in person? Yes.
I think as soon as you see schizophrenia, you immediately think no decision-making capacity, which is not true. I mean, people with schizophrenia can make confident decisions. I remember a story of a patient saying, I have to be all together when I meet Jesus,
Yep.
right?
Yeah.
I'm not comparing that with schizophrenia, but I mean, it speaks directly to what kind of narrative, what kind of script
Yeah.
is going on in your life.
Yeah, absolutely. No, thank you. Sometimes we have buzzwords, right, such as specific behavioral health or mental health complexities that may alter or bias how we perceive of this patient. And schizophrenia is one of the most commonly misconceived behavioral/mental health complexities, because you're exactly right. A lot of times people are like, oh, well, they have hallucinations, AV, so we can't trust maybe, or we can't determine that they do have capacity. Yes. So a corporate guardian this is a term that's used in Illinois, and it's just someone who has legally been appointed by the state, as opposed to a familiar guardian or like a durable power of attorney. And so this individual actually went into the guardianship system and then was appointed a guardian, and then went through a temporary guardian, and then went through the final process of receiving a permanent guardian. So they went through the entire process and have a permanent guardian.
Decision.
Well, they do, which is interesting. They do, and so that's why this is very interesting, and it's important to note. So someone else technically should be making decisions for him. Mm-hmm. Okay. We must consider the impact of having the surgery could have on this person's ability to care for themselves. Could this impact their living situation? Absolutely right. So what are the other social implications regarding this patient that would help us figure out what's ideal, as well as what are some alternative options, right? Because part of ethics, if we can, we like to give a range of ethically permissible options. And usually they range from most ideal for the patient to most ideal for the care team. And then we try to have people meet somewhere in the middle. Yes.
Yeah, and why is he adamant? I would just want to know why, right? What are you afraid of? What are the thoughts? There may be all kinds of inferences he's making about what's going to happen, and it'd be helpful to talk those through.
Absolutely. Is it him? Is it more than just him? Is he having conversations with internally, and everybody is unanimously decided that it is not going to happen? Yes.
Also wondering what our assumptions are about us being in a group.
Oh, that's
Is that a loaded kind of phrase for some, and does it people presume that he doesn't have the capacity to
make his own decisions. It makes me think about concept of supported decision-making. Where
Yes.
you retain some of your own rights to do so, but you have someone helping you do it. Doesn't seem to be in effect here.
Absolutely. No, that's a great point that you bring up, Kathy. The group home may imply either that there is some inability to provide, you know, ADLs, right? Their daily living, and or that there may be some additional complexity. Maybe there's some developmental delay or intellectual complexity or physical delay, right? That could also contribute. No, these are great, and these are all very valid points, right? So now let's look at the case with more narratives. So what if we were to say that Patrick is a 52-year-old African-American who presented to the ED from a group home for leg swelling and possible gangrene. He has a history of schizophrenia, HLD, HTN, COPD, and has a corporate guardian. He has no living relatives, but a good friend at the group home whose family he is close to. A workup reveals that he needs a BKA, and he's adamantly refusing, stating, "I'll die before I lose my leg. Y'all just want to cut on Black folks. And how will I be able to go out and panhandle?" Though the guardian is difficult to consistently reach, they are consenting to the recommended amputation, though the care team is concerned because of Patrick's consistent and adamant refusal. So when they do talk to the guardian, he's like, "I don't see what the big deal is. This is why I'm the guardian. Cut his leg off." And they're like, "This man is telling us that he gonna pull out IVs and get up out of here and hobble out this bad boy before he lets," and so there is valid concern. So here are just some thoughts that we want to consider, right? So is Patrick considered to have capacity, agency, or both? Right? What is the narrative significance of Patrick's case? So we saw the case without some of those narrative specifics, and then we saw the case with some added narrative specifics. And then how can the care team acknowledge Patrick's refusal and still provide care? So any thoughts? I think the first one, does he have capacity, agency, or both? Just based upon what you've received.
He has agency. It's hard to know if he has capacity at this time with the information that we have.
Mhm.
At some point, he did not have capacity
Mhm.
because he got a corporate job.
That's absolutely right. So while we don't have his records, we do know that if he has a corporate guardian, then he's actually at least been declared incapacitated, if not legally incompetent. But the very presence of a guardian means that the courts have decided that he does not have enough capacity to X, Y, and Z, right? And we can also determine that based upon living in the group home, that there's some limitation, whether it be physical, mental, or otherwise, that maybe prevents Patrick from living maybe what he would consider his fullest life. What's the narrative significance of Patrick's case? So we found out that he's African American. We found out that he wants to know how is he going to go out and panhandle. And we found out that he has no living family, but he does have a friend whose family he's close to at the group home. How does that change how we think about this case? Or does it just provide us with more information like, that's what I wanted from the first slide? Yes.
I mean, it does help to provide more information, but the information that it provides gives you a lot of context into how to consider the no, right? Right, like you said earlier, that no is a story, there's a narrative there, but on the first slide, we just knew the opening line.
Yep.
And we didn't understand, is this no because I understand that it means that I will die and I genuinely would rather be dead? Or is this a no because, which is seeming like it could be an option, it's unclear, but is this a no because you have a long-standing reason to be super mistrustful and there's a genuine concern for how you will continue to meet your needs and whether this is a barrier that, how this is going to impair your life, and there's probably a lot of fear and distrust surrounding this.
No, I think you're absolutely right. The significance allows us to take into consideration the narrative of the no, right? We're still assuming, right? So until we actually talk to Patrick and be like, so what's, are you really afraid of losing a leg? Because we can get you another one, right? Or follow-up conversation. But to know from the outset that there are certain identifiers, right, that may predispose Patrick to having a certain kind of anxiety or apprehension about losing agency or autonomy as well as part of his body. Yes.
Similar to what Kate was saying, I think it helps us to think creatively about the next question about where.
Yes.
So do we want to bring this family into the conversation?
Yes.
With a phone call, we can bring them in person. If we're looking for like a support group of other amputees, we can figure out how we pull that in. In terms of timing, if we don't have to do the amputation during this admission, and usually, despite my friends' feelings of vascular surgery or otherwise, usually we can wait a little bit.
Yeah.
Understanding it presents a risk, but not for no reason, right? And so if we discharge back home and give them information about what to look for, what concerns are. Maybe that's where we're going. Bringing in a second opinion, and then if he's concerned again about, or not concerned, but appreciating his position, especially recognizing the abuses of the healthcare system in the past, thinking creatively about what sort of second opinion could help or what sort of support group could help. So could a second opinion from a particular physician, maybe one he already trusts, be particularly helpful? I assume it would be. So again, just knowing more of the narrative helps us to think more creatively about how we can support them.
Absolutely, absolutely. And I appreciate you transitioning into that third question, because that's absolutely right, right? It allows us to think about alternatives, alternative ways of having this conversation with Patrick, but being mindful of the fact that he wants alternative options because he is not consenting or accepting what we are recommending. I see that. Yes.
Had a very troubling thought,
Uh-oh.
though, about this case.
Mhm.
And the thought is that Patrick's prognosis is poor. Even if we discharge him with his leg on, as my Aunt Helen would say, he's gonna be back.
Yeah.
And eventually that amputation is going to become if we don't amputate, you're gonna die.
You're absolutely right. And as it said, he had recurring admissions for the same thing,
Yeah,
right? So
yeah,
we've
it's gonna
been going
continue.
through it, yes.
So
Absolutely.
how does that shape the narrative, in the extended narrative in this case?
I'm gonna go ahead and have you, and I'll respond.
No, go ahead.
Okay, so I think what that does is it provides a compromise with what we think of as optimal medical care or ideal with a beneficent healthcare, right? So like, what do you think? Tell me what's good for you, and let me see if I can provide that. This is what I think is best for you. Tell me what's good for you, because you're pointing out something that I'm sure many of us have dealt with. We do get to the point where we have to offer alternatives and alternatives until they're in a state of emergency where they can't refuse. And as unfortunate as that is, what it does do is it says we have provided every opportunity for this patient to express their autonomy and live how they want. And now it's life or death. And we like to err on the preservation of life. On that side. And so I think that's a major gap. And I think that actually extends into the narrative of public health. Because what does it look like for him to go to a clinic and get this maintained as opposed to making recurrent trips to the emergency department? Or if he's afraid to go to the community clinic, or if it's one physician for 1,800 people or something outrageous, what are the barriers that kind of contribute to this narrative, right? What are those competing narratives? So you bring up a very fascinating point, which is how do we connect our inpatient institutions to public health and do that in a way that's ethics-based in an equitable manner? And I would love to have the answer for that because my job security.
This would be a very frustrating
It
scenario
is.
for me.
We get these calls.
Because I know I would see it loads and loads and loads of times.
Yep. And it's the same, you would not imagine the number of BKA and AKAs that are walking around refusing, and they come in time and time again. We give them, of course, antibiotics and staves it off for like a month or two, and then it's same thing. Also, the transient lifestyle, right? And so, I didn't want to, okay, the next slide, we'll see kind of a little bit of the discussion so you all can get some more narrative, so you can get some answers to these questions that will help you all have a better understanding of the significance of Patrick's agency within this refusal. Oh, I see we have I wonder.
From online.
Okay, I wonder what the friend and family think about this choice. Would they support the decision, or could they help Patrick talk more about with the care team about this procedure? So again, this concept of shared decision making. I think it's something that we would love to imagine happens from jump, because we like to think that all of our departments and areas speak to one another about the care of their patient. However, we know that there needs to be some connectors of conversation and some mediation masters to make sure that everybody's on the same page about what's going on, the prognosis, what are the options, right? And so being mindful of if there's anyone that Patrick has an affinity towards or trusts, we want to bring them in this conversation, right? Not only because we want Patrick to feel supported, but we want to make sure that we understand where he's coming from. And if we question his capacity, it's going to be helpful to bring in individuals who can support his decision-making, right? And support his agency. And so that's going to be very important. Thank you for that. Don't hit the wrong button. There it is. So here's a little bit of discussion right here that might be helpful. So additional conversation with Patrick and the workers of the group home revealed Patrick's livelihood involves walking the neighborhood and panhandling at different areas. He is well known throughout the community and is welcomed. He goes to the gas station and sweeps up and they give him a bag of chips and a pop. He is mostly adherent with behavioral health medications and managing comorbidities. He takes his blood pressure medication. He takes his schizophrenia medication. He's not non-compliant. He does adhere. And though Patrick has a guardian, he still possesses the agency to refuse, right? And so while he may be at a group home, it's clear that he still is able to ambulate and get around, right? In addition to being able to get around and ambulate, he's able to express his agency verbally. And so we just want to be mindful of that. Now, I won't tell you all what happened to Patrick, but I think you can imagine, I'm sure that there's a case similar to this. You're like, I know what happened to them though. And so being mindful again of the narrative, and the more that we get of the narrative, the more we're able to find alternatives and ethically permissible solutions that can prioritize and take into consideration the narrative of the patient, as well as the narrative of the care team that's providing care. Okay, so we got another case. Oh, yes. Go back.
We accepted that the guardian was evidence of not having capacity, but that's a legal designation. It's not an ethical assessment of where the person is. And if they're not overtly manifesting symptoms, like those were two cogent reasons for not wanting that all of us immediately understood and accept as reasons.
Yes.
And so I think
Yes.
the obligation there is also to work through, like you said, here's what will happen if you lose your leg, or you can still get around,
Yes.
or look, you're welcome. They're going to be with you. There are a number of steps, and this is someone capable of deliberating.
Yes.
And this is an obsession of mine over the way decision focuses on the end result.
The end, yep, and not the
rather than
process.
working with someone through the process. And this person seems very capable of reasoned deliberation about their future and welfare.
Absolutely right.
And maybe bringing in the friends will.
Yep.
But also, we can't cede it to the law to determine what was true at a time when that decision was made.
This is more layers though, right? Because, yes, and I think there might be different pathways, as you have said, and Kevin, you were saying, can we give this person some time? Can we return them to their community, et cetera? Are there things that we can do? The hospital system is gonna have their risk managers and their legal counsel
Absolutely.
also involved, and they're gonna say, is this, it gets medical advice, and we're putting the patient at risk, and this is not an appropriate discharge, and all the things we know.
Yeah.
And so what actually happens may not always be the ethical thing to do.
Yeah, that's why I wanted to
Yep.
open that up.
Well, and I think you've kind of mentioned this, LaShaunda, but you would have a capacity assessment specific from the care team. And in a case like this, I tend to recommend they bring in psych, because if there's ever a time for a second opinion,
Yep.
cutting somebody's leg off without their permission is a good time for that. And so having clearly documented capacity. So the evidence of a guardian meant at one point they lacked competency, but not necessarily capacity. And so that would allow you to interface with the guardian a little differently too, in case the guardian calls you back and they're like, well, you said he needed this treatment. What do you mean he's going home without it?
Yep.
You say, well, he was able to show some insight. But that's where, for me at least, I'm not as convinced based on this yet. I'm convinced that he has deep-seated, genuine concerns and reasons that need to be addressed. But capacity of being able to discern what getting it versus not getting it looks like versus what the underlying cause of the infection is, what source control actually means, how you had infections before and the antibiotics worked, but why they're not going to work this time. Like that's the sort of manipulation we're going to want to see to make a better decision about whether you can, whether you should be making a decision that could negatively affect your health overall. Nobody wants to see that. I mean, nobody wants to cut the leg off against his permission.
Yeah, correct. No, you're absolutely correct. But then, we do have times where we have to consider, based upon the circumstances, prognosis, and proposed intervention, do we temporarily override autonomy? And usually, and I would love to hear, it's usually only if it may increase the autonomy of the patient after. I've never seen us where we say we're going to do something that, for example, an elderly patient has a UTI, and so that makes them delirious. And so they're refusing antibiotics. But we know that delirium comes with the UTI, and if we treat the UTI, the delirium may go away. So that may be an instance, and it's also not as invasive, right, as that we may temporarily override. But again, risk management's going to be involved, legal is going to be involved. There's going to be a multidisciplinary care team because we need to make sure that we've clearly documented everything and that we have medically backed support to say it's actually more advantageous to their choices that we temporarily override their autonomy so that they can express a greater degree of such after such intervention. I don't know if this is one of those cases because the leg is a very invasive, it doesn't grow back. You only get two. The toes are different on each side. And so we got to be a little bit more, speaking from experience, right? You got to be a little bit more sensitive about interventions, especially if they are more invasive and have more long-term side effects or consequences. Yes.
The fact that he's a panhandler, to me, that would be really compelling because he's right.
Yeah.
You can't panhandle that well if you're in a wheelchair. So maybe part of the therapeutic process would be to try to get him to trust that he would be okay with an orthosis or a prosthesis or something, like that. If you can gain his trust and maybe show him people who are in fact, out there on the streets and they have an artificial limb and they're doing fine.
Absolutely. I think the truthfulness goes to the trustworthiness, right? And so we know what he's refusing, but we also know what his concern is. So that's where you can enter into the conversation and become a partner. We don't want you to stop panhandling. And so we're going to make sure that the options we provide you in some way, shape, or form may not take away from that. That may be all he needs, right? It may be that simple. So if there's anything that provides an entry into conversation, into commonality, right? Even amidst the patient or surrogate refusal. That's going to be our small little window that we can climb in and say, I'd like to go alongside you with this, knowing that this is what you're concerned about. You're not concerned about your leg, you're concerned about the mobility without having a leg. Okay, so let's address that mobility. Absolutely correct. Okay, we got one more here. So this is case L. So Lacey is a 17-year-old pregnant patient who presented to the ED for vaginal bleeding. She's 24 weeks pregnant and at 16 weeks had a rupture resulting in a high-risk pregnancy. She's struggling to carry until full term. Lacey initially agreed to a workup which led to her admission, though she is currently refusing medically indicated interventions, including supplemental IV fluids, constant monitoring, and a recommended C-section. She has received medication to control the bleeding, and the care team has asked Lacey about the whereabouts of the unborn's father, but was unable to provide information to contact the person. What are we thinking? What's missing? What sticks out immediately? I know they're good and vague, yes. Mm-hmm.
Call that word currently. Does that give us an opening for conversation, like why is she currently refusing this?
Mm-hmm. No, that's good right there. Mm-hmm.
What's the difference?
I'd like to know if she wanted this pregnancy, whether she wanted an abortion. She may not want this pregnancy and therefore is refusing treatment.
No, that's good right there, right? What are the circumstances surrounding this pregnancy? Do we have any other questions, concerns, or comments? Yes.
Why is she struggling to carry to full term? Is it a medical issue or is she lacking social supports? Generally, I tend not to care about the father being there, but does she have other support systems we need to loop in to make her feel more supported?
Yes. Oh, we have lots of questions. Yes. We need to know about the support system. Yes, that the patients could be, I know there was, yes. Is she considered an adult in her state or does she have a legal guardian since she's under the age of 18? If so, where's the guardian and their thoughts about this situation? No, that's a very good point and I'm going to respond to that. Supported by her parents, does she have other children? That's a great question. We don't get into that. So I will say that usually children are able to provide assent after a certain age, but that's not the same as consent until they reach legal adulthood. However, exceptions apply to pregnant patients. So even if the patient is not 18, they still have the ability to consent or refuse medical treatment or intervention. And so that's supported by the American Colleges of Obstetrics and Gynecology, as well as AMA and all those wonderful, wonderful associations. And so the reason for that is with the complexity of bringing life to fruition via pregnancy, right? The medical community feels that it is ethical to make sure that that person has the agency and autonomy to be able to make decisions about that process. She's working hard to keep that baby, so her refusal suggests a diminished capacity at this time. Oh, that is very interesting. Though that is very, I don't, you know, we're gonna keep that. We want to address that for the next slide. Oh, that's wonderful. Okay, so you know, this is our bare bones case. So now here's a case with a little bit more narrative. So Lacey is a 17-year-old pregnant Hispanic patient who presented to the ED for vaginal bleeding, 24 weeks pregnant, at 16 weeks had a rupture resulting in a high-risk pregnancy. Struggling to carry until full term, Lacey proudly admits this will be her parents' first grandchild. Initially agreed to workup, so she agreed to workup, which led to her being admitted, but now she's currently refusing. Lacey's undocumented mother, who she lives with, is at bedside and supports Lacey's decisions. Lacey is diabetic and adheres to her insulin regimen. She has no other comorbidities. She has received medication to control the bleeding, and then the care team asked Lacey about the whereabouts of the unborn's father, but she says they are estranged and was unable to provide information to contact the person. Does this change anything with the additional narrative? And if so, what changes with additional information?
Sounds like she's proud to be pregnant and to have an opportunity to have her parents' first grandchild.
Yeah. Yeah, so there's some pride. There's some pride, right? Knowing her ethnic identity, it's a good possibility she's probably Christian and also probably Catholic. And so the concept of abortion is not an option. And so thinking about also cultural, because we only know Hispanic, and so don't want to do is equate that to a monolith. But what we do know is that there may be language barriers. There may be cultural sensitivities that we might need to dig into, right? There may be some religious factors. Lacey's undocumented mother, given our current political time, that's probably one of the most alarming aspects about this, especially the fact that she's in the hospital at bedside and we know she's undocumented. I think maybe 3 years ago, that might not have been such a big deal, but when politics and economics and society changes, medicine changes as well. And so we have to be mindful of what that could mean in the process of caring for this child if we were to have an ICE incident, right? Also, Lacey being diabetic. We're not sure if this is gestational diabetes or if this is type 1, type 2, but we do know that it is controlled and that she also doesn't have any other issues. I appreciate your comment about not caring about the dad because they're estranged. So we know he kind of hasn't been involved and so we are okay with Lacey and the mom is, making decisions. And they're like, I ain't talked to him in 7 months, honey. So just a couple questions to consider. Click the right button, Lord. And I think I broke my. Oh, thanks. Thanks. Okay, here we go. So is Lacey considered to have capacity, agency, or both? What do we think?
I think we're again to the point where we're seeing agency capacity. I'm gonna wanna know a little bit more about why she's refusing. So refusing IV fluids and monitoring for C-section is gonna be a pretty different analysis for me.
Yeah. Yep.
Conversation around the C-section, I would wanna wait on that first. Those get real complicated real fast, but conversations around monitoring, for example, like, is it that she wants to walk around the room and it's really uncomfortable? Or is it that you think that every time somebody touches you, you're gonna get an additional charge? And we could think of a whole bunch of more things, right? I think we've heard along the years of like, oh, okay, so some of this might be a misunderstanding. So it turns out that your bill's already gonna be high, it's not gonna be any higher than monitoring.
Yeah.
I'm being facetious, but honestly, like, monitoring's not gonna up your bill,
Yeah.
right? So we can talk about financial counseling, if that's a concern, we can go through that, but we can go back and forth about what some of the misunderstandings might be. Or is it, again, it could be just an aversion in general saying everything's gonna work out fine. And the more we talk about this stuff, the more I see things on the screen, the more worried I'm getting. And this anxiety is snowballing. So let's just not do any of this.
Absolutely.
Those would be quite reasonable, right? If instead the person said, none of this is actually happening to me, like they're not telling me the truth and everything's actually fine with the baby. that would make me really concerned about capacity.
Okay, no, I appreciate that.
I think too, I think often, if this is her first child, which it seems to clearly be, if it's the first grandchild, et cetera, that a lot of women have in their heads that it has to go this way naturally with no medical
Mhm.
intervention and this and that. And that can also be part of her, reasoning for not wanting the intervention. It's
Mhm.
just, it's like, nope, this is gonna be baby naturally the way I envisioned it, and that's the way.
Yeah, I see we have some, I would want to know more about what she's concerned about regarding the medical interventions. Does she understand them or is more info needed? Yes, so again, if she has capacity, why would she be refusing medically indicated interventions, for sure? And then look to get her on board with continuing to work to keep the baby, and she has to be tough to have gotten this far. Yeah, so right, if we're trying to appeal to the personal character of an individual, especially if it has been communicated that this is what they want. So I think we always have to clarify that before we're like, well, you're tough, you got this far. We want to make sure that they want to get this far, that they want to continue, because it could perhaps be a very dangerous and difficult situation. But yes, Lacey has both, right? So she has agency for sure, but she also has capacity. Now, remember, capacity is spectral. So we don't say how much capacity, right? It could be 9 out of 10 and the refusal could be a traumatic experience, or, 6 out of 10 if the scale point is 10. But based upon the information that we have, we at least know she's supported in her agency, and there seems to be no question of her capacity other than her refusal, which is a question of her capacity. The narrative significance to Lacey's refusal. We only got one more slide after this too. I appreciate y'all because it is after 5.
I was gonna say, I would want to say to her, tell me more, what's at stake for her? Is what I'm
Yes.
wondering.
Yes.
And is there a dynamic with the mother? Like, this could be a negative dynamic, it could be a positive dynamic.
Yeah, does she change
We
when
don't
leaves the
why.
room?
Because I'm curious, the initial, like, why did you come here? What were you worried about?
Yeah.
That shift.
Yeah.
And, is it now that your mom showed up and has this story that you have to have this birth in the following way? I
Yeah.
don't, it's hard to know, but that shift is telling.
And often family dynamics complicate
Yeah.
decisions. I mean, we've seen people flip between depending on who's in the room and who's out.
Yeah.
And it changes day to day, every day. And care teams just run around like chickens with their head cut off because they don't know who to believe, what day, what time. Yes. And then how can the care team acknowledge Lacey's refusal and still provide care? That's gonna be a little difficult. Or maybe not. I think if she doesn't want constant monitoring because she wants to walk around, oh, okay, well, we'll give you intermittent monitoring. We can compromise to that, right? Or if you don't want IVs, will you promise to drink a bottle of Gatorade every hour, right? We need to come check and make sure your output and input match or things like that. So, okay, and then this last one, so the discussion. So additional conversation with Lacey revealed she had previously suffered a miscarriage due to medical complications from a previous admission. Though Lacey was refusing interventions, she did not want to leave the hospital and was consenting to intermittent monitoring and oral supplements. Lacey revealed a history of domestic violence, but was unclear whether the violence involved the unborn's father. Lacey was refusing a C-section presently as she wanted to attempt to carry until 27 weeks. And so she had very clear reasons for her refusal, and all it took was follow-up conversations. Tell me what's going on. What will you agree to? How can we help you, right? And so at the end, I think it's just very important to understand the intense human emotions that go through patients as well as surrogates' minds and their hearts, but also how can we emphasize and acknowledge agency in a way that treats it almost the same as capacity, knowing that they're two clearly different things and that we still have a medical or clinical obligation to provide a certain kind of care. And so with that, y'all, that's it. I appreciate y'all. Fantabulous.
Are there any other questions or comments online?
Because I know we're tired.
Dr. Reese is willing to stay.
No, I'm willing to stay up, put my foot up.
It's like,
What do you want in fetal distress that they didn't finish their question? I don't think.
Well,
Everybody else is just, this was awesome. And thanks.
I agree.
Yeah.
but I think the pregnant patient case was important because one, even the language that you use when you're trying to do these cases is important. Unborn versus fetus versus baby. I mean, you gotta be very, very sensitive to that. But also understanding that this is one of the few times again where the care team really have to decide, and usually it's multidisciplinary with risk management and ethics. is the harm going to be irrevocable to the unborn? Is the harm going to be irrevocable to the child? What's the likelihood of adverse side effects? And then again, as I stated previously, there are some instances, especially if the life of both are in jeopardy, where the care team has to make a decision to try to save at least one life, right? And those are very, very complex, and we hope that they never do that without some kind of ethical intervention. But there are certain moments, and if fetal distress is one of those things that are taken into consideration regarding such. So, okay, no questions, comments, concerns, quips? Y'all have been wonderful. I appreciate that. I appreciate y'all.